I want to get a little controversial here, but we have a lot of other agents in ALL. We have recent approval of BlinAtooma. We have ADC targeted agents. Some of these are targeting the same thing that the CARs are targeting. So should we be treating these people with BlinAtooma before they get CAR T cells? What's the,
These are off-the-shelf products.
Exactly.
Right? Yeah.
Now, first I'd love to see a comparative trial to address this question, but I think that for BlinAtooma, the short answer to this is BlinAtooma will only put about 40% of patients into remission if you have bulk disease. And that's been shown in multiple adult and pediatric trials. But if you have minimal residual disease, BlinAtooma can put 80+% of patients into an MRD negative remission.
But do they stay there?
If they go to transplant. And again, with in both adult and pediatric trials, if your intent is to get a patient into MRD negative remission and take them to transplant because you have a transplant eligible patient, that's a reasonable approach. Now, whether CAR T cell is as good or better, that would be a nice trial to do. But I don't recommend BlinAtooma in patients that have bulk disease. And the reason why is CAR T cells are so much better at getting them into a deep remission, and that's the only way to cure in ALL, is a deep remission.
Right. Can you see ever a sequential CAR T, BlinAtooma in some sequence ever, or?
Good question. I think if you have CAR T cells that work, I don't know that you need BlinAtooma. I think inotuzumab presents a different challenge after inotuzumab therapy, and inotuzumab has a higher chance of getting patients into deep remission in the 70 to 80% range. The one challenge with inotuzumab is increased risk of veno-occlusive disease, liver toxicity, and it must be followed by a transplant. And so, you've got to kind of make a choice. But there again is another good trial looking at inotuzumab versus a CAR T cell based approach.
Yeah, so we have extensive data in the adult population with, I think, 40 to 50 patients treated with various CD19 CAR T cells. And our approach in the adult setting is that we should refer patients for transplant if they get into a complete MRD negative remission and they're eligible for transplant, which usually means they haven't already failed a transplant. So our data seems to support that being more of a bridge, which is a little bit different than what the UPenn data was suggesting. I think that this is a very controversial area, and we'll need to do longer term follow-up to do that.
I agree. In adult populations, we need to know whether you can have a long-term response with a 4-1BB vector like you do in children. There's some suggestion that some patients can respond long-term, but whether it's as good as children, we just don't know yet.
So one of the worries in the post-allo transplant arena, and again, this is the one case where many of those patients had failed at prior allogeneic stem cell transplant in the original data, is that whether this cytokine storm or the other toxicities is going to massively increase the risk of reactivating GVHD. Has that been seen in the clinical trials?
We have had, just to give you perspective, in the Eliana trial, we had one patient that we worried had got graft versus host disease, and it was biopsied, and we carefully looked for the presence of CAR T cells, and we couldn't find it. There are other patients that I've heard of anecdotally. We used to worry that it was going to be a big problem because remember, 65 to 70% of the patients who get CAR T cells and go on these trials have already had an allo transplant, and so you are putting the CAR into their transplanted T cells from their donor. So we used to really feel that it was going to be a problem. If it is a problem, it's pretty subtle because we don't see it.
Right, so what else do we know about mechanisms of resistance in general in these populations?
I think the two mechanisms of resistance which have been characterized to some extent CD19 loss on the tumor, making it escape attack from T cells, and the other one would be T cell exhaustion. So T cell health, and is there something which is leading to more inhibitory molecules such as more PD1, PD-L1 expression, leading to another way of tumor escape, or even the loss of CAR T cells over time, where there's an expansion, but then the CAR T cells are gone. So those would be the ones which come to mind.
So how do we solve that?
I think one way to look at it is to look at tumor biopsies in patients who are relapsing, and you can stain for a CD19 to see if CD19 is lost on the tumor. If we have a better way to detect CAR T cells easily in the real world, as was just mentioned, maybe B cell aplasia would be a surrogate marker. Immunoglobulin levels could be a surrogate marker, but maybe a much more easier way to actually find out if someone's really had a very good response to CAR T cells and then somehow escaped, and can you then retreat? If someone got a CR with CAR T therapy, the tumor still expresses CD19, and now the reason for relapse is the CAR T cells which were there initially are lost, then maybe a second dose of CAR T cell. I would not advocate that for everybody because it's expensive, it could have side effects, but really a targeted population. So I think this whole group of patients who have relapsed post-CAR T, that was also presented at ASH this year in the real world, and that's probably the next unmet need. And trying to understand the mechanism of relapse and trying to target the right treatments for that population is the key. Right now, the trials which are ongoing, some of them are adding PD-L1 inhibitors, post-immunomodulatory molecules, post-CAR T. We have the platform study, which is looking at that after lysocell, and other studies which are in that space. But I think individualizing that a little bit mechanistically would make more sense.
So two things to mention that are happening at ASH now as well. In order to overcome the problem of CD19 negative relapse, we absolutely have to target more than one antigen. ALL is the best model to really look at antigen selection because you can do flow cytometry and see beautifully what antigens are there, and you can really have a great way of targeting them. There are a whole series of now the next wave, and the next wave really is multi-antigen targeting. A number of studies have been presented that show CD19, CD22 combinations, and they're done differently. Some have them on the same construct, some have them on different constructs in the same cell, and some have pools where you've got CD19, CD22, and then CD19-22 together. And these very interesting and intriguing studies so far have shown high rates of remission, but we don't know how long they're going to last. And we have to be careful with that, because if you put a whole bunch of multiple antigens on a CAR, you may exhaust it. And you may not get those long-term responses that we're seeing in some of the 4-1BB vectors like TISAGE and Leclocel. So this next wave, I really think in order to be successful, we've got to figure out how to have long-term expression in ALL of two antigens. Take your pick, CD19, CD22, CD19, 123, whatever it is, in order to succeed.
And understand that we take the lead a little bit if you think about multi-agent chemotherapy. This is multi-targeted CARs. I guess the one question is, I guess the concern I have might be, would you wind up with a CD19, CD22 negative recurrence? In other words,
absolutely.
Yeah, that's the
concern. we didn't start curing ALL until we used 3 agents. Yeah. And then we had to take care of the CNS problem too, but it's 3 agents that did it.